Welcome back. Now, the changeover from the National Hospital Insurance Fund to the Social Health Authority has been one of the biggest undertakings of the Kenya Kwanza administration. It has, however, failed to win public confidence, with system challenges that have forced Kenyans to dig deeper into their pockets despite costlier deductions and an integrated information technology system valued at 104.8 billion shillings. Olive Barrows sat down with Health Cabinet Secretary Deborah Mlongo Barasa to take stock.
No public service delivery project of this scale and ambition has ever been undertaken in the history of our country. Those are the words President William Ruto used in his Jamhuri Day speech to describe what has now been branded Taifa Care. I sat down with Health Cabinet Secretary Deborah Mlongo Barasa, and I began by asking her what it's been like having been thrust into the transition from the National Health Insurance Fund to the Social Health Authority midstream.
Wow, absolutely. Yes, I did feel that. And thank you so much for having me today, Olivia. You know, UHC was being rolled out nationwide, and definitely the ambition, you know, the difficulty of rolling out a nationwide project that involves various pillars is really, you know, a heavy task. But definitely it is one that I have loved. I would love to take, and one that I am really obligated to take. Why is that? Because I have been a doctor, I've been an intern, I've been a medical doctor and a physician. I've worked in the slums of Nairobi. I've worked in different levels of care, from community level up to level 6, the National Referral Hospital, which is Kenyatta National Hospital. Additionally, I've worked in various international organizations, including the World Health Organization. I've visited various countries, like, you know, Sudan, we've visited Zambia, Malawi, South Africa, Nigeria, you know, all around. And I've seen the challenges that we've had, yeah? Health systems are a challenge in Africa, okay? And so we need to look at sustainable solutions. So being given the opportunity to implement UHC is really something that I'm passionate about, because I remember of the vulnerable, the needy people in the community that we had to send back home because there was no money and you could actually offer the services, the health services, but because there's no money, then you send the patients back home.
How did you learn of your appointment to the office?
When I had the appointment, first of all, I was asked if I am ready to take office. Are you ready for Mafia House, you know? And I said, you know, when this is informed, you know, you're given a task for the nation, and you have the wealth of knowledge and experience and the desire and passion to support the country, how can you say no?
So you received a phone call?
No, I was informed. Yes, I was informed through a phone call. Yes, the appointment that was given.
So who was on the other end? Felix Kosgei, the head of the public service?
No. So after they called out our names, that is when I received the phone call. Yeah, and it was the president, and for me, I was, yeah, you know, shocked.
What has been the most challenging aspect of the SHA rollout? What keeps you up at night?
I don't lose my sleep. Definitely, I always ask myself, how do we engage the community? How do we reach out to the last mile? And, you know, it all involves stakeholder involvement, political elite, the development partners, the implementing partners, you know, the various stakeholders, that, like the healthcare providers, the healthcare workers, the human resource for health. And at times I ask myself, because, you know, sitting on boards with donors, you know, like at that time they were shunting their resources to the Gaza, the challenges they were having in Ukraine and so on. And at times there's a change in the political offices. The governments have their own policies, they have their own agenda. And maybe Africa will not be the agenda. How do we strengthen our health system? You know, at times I hear people say, I earn $1 million, I earn 200,000. But suppose you lose that job, suppose you lose your wealth, you will still go back to the same health healthcare facilities that we have in public hospitals. I have seen it with my 2 eyes. You know, the elite, you know, losing everything, or someone being involved in a road traffic accident, and they still come to the public facilities, yeah? And then, again, the tight fiscal space that came in during the Gen Z movement. Again, those were things that were really worrying.
Rural Urban Private Hospitals Association, they are saying if you do not pay their debt come December 31st, patients will have to pay out of pocket.
We acknowledge the challenges that we have as a ministry. We take every feedback very seriously from RUFA, from all the stakeholders that are involved, the healthcare providers, etc. You know, the program is less than 100 days old, so these are transitioning challenges, but again, we are committed to improving, to an improved, efficient and effective system. And this is through engagement. So one of the challenges that was raised was the pre-authorization, the training, capacity building, because the system, again, as time goes on, we are again trying to tweak it and alter it a bit. And so we are looking to routinely capacity build, have mentors and supportive supervisors within, you know, the facility level and also at county and regional level, so that they can always engage with the healthcare providers and ensure that there's a seamless transition.
But on the question of debt, we had an average of, what, 30 billion shillings, as I understand it, of debt owed.
So we had 19 billion. We've been able to pay more than half of the debt right now, okay? So their commitments, and let us take note that these are debts that have accrued over the years, more than 5 years ago, and we are really trying to pay them off, yeah? But even as we look, I would wish that RUFA looks at the ultimate goal.
But will you meet the deadline that government set for itself of December 31st?
We'll work to it. We are committed to resolving the issues promptly. Again, looking at our financial constraints again. So we'll be engaging them routinely to ensure that we support where we can.
So how much is paid and how much is pending?
We've paid 9. I believe we have paid 9 billion, and I think it is 9 billion that is pending. But I'll have to check the figures. Yeah.
All right. You mentioned the systemic challenges,
yes.
Right? This is a system which has cost us 104.8 billion shillings. When the system was first rolled out, we were forced to reverse briefly back to the NHIF system, then a manual system. Is it working now?
We are not at 100%, I can assure you, yes, but for what they had promised the government, they've been able to achieve. Now let us remember that this is a 2 to 3 year plan implementation, and you can see the system is there. Yes, there are challenges, again, in terms of having, you know, a seamless and fast-growing, a fast system, and we are reviewing the system routinely, okay, to customize it based on our needs as Kenyans. And again, let's look at the other issues: transparency, yeah, visibility. We are fighting corruption by reducing the human-to-human interface, yes, and then also looking at the issues of supply chain. We were meeting with the MPs here, and they were telling us, how do we ensure that the drug gets to the last mile? How do we monitor to look at the capacity? Because at times people come to the facility and they say, hakuna dawa, you see?
Wasn't this system tested before it was launched?
It was tested, but it was not customized again. It needed to be customized to our setting. Anyone who has, you know, started a program and set up a system, at first it has hurdles. Now imagine setting it up nationwide, yeah?
So my understanding, or what I've read, is that the system started working when Savannah Informatics was brought on board at a cost of 1 billion shillings. Is that going to be covered by the 104.8 billion shillings, or is this now another additional cost that the taxpayer will have to incur?
So this one will be, it is within that 104.
Authorizations, as I understand it, for surgery, for instance, can take anything from 3 days to 1 week. How is that being resolved?
It has been taking long, but because we have been able to mobilize resources, and again, we are giving that task to the healthcare providers at a facility level so that they can be able to conduct the pre-authorization, and up at the SHA level, they're able to ensure that there's a justification and ensure that there's accountability and transparency and the quality is not compromised, and the healthcare providers are actually doing the right procedure we are working in that in the human resource component, both at SHA level and again at facility level.
Sticking with pre-authorization,
yes.
Clinical officers say they wrote to you, and they're not allowed to pre-authorize specialized procedures, and they say they see up to 80% of patients.
Ideally, the quality of care bill was supposed to be passed together with the other bills, but because of the Gen Z movement, then it was not passed. Now, the quality of care bill was supposed to address these issues so that we have one body, we have one body that covers the clinical officers, the nurses, the doctors, conducting assessment and panelment again. And then now again, the regulatory bodies, the professional bodies again working together. All right. So because of that, then again, we needed to change our goalposts.
You talked about empanelment, where clinical officers are concerned,
yes.
And they say this policy of requiring the Kenya Medical Practitioners and Dentists Council
yes.
to more or less essentially vet them is against the law, because they say the policy cannot override the law.
And I agree and I acknowledge, yes, there's that element, why KMPDC, yes. But that is the single source of truth for now, because it covers more than 98% of the healthcare facilities. And I told the clinical officers, we are addressing this. We understand the challenges that you're having. They may feel discriminated upon, but we want to table the quality of care bill. And once it's passed as an act, then all these things will be ironed out.
So the other day, October the 30th, your principal secretary was talking about those who feel the benefits package is insufficient.
Yes.
Go ahead and get private insurance. Why are we paying so much if we have private insurance?
I absolutely agree. And what we said, we have established a committee, a benefit package advisory committee that will review. And I am really critically looking at who are the people that will be, and they need to add value. Technical people, stakeholders, patients, we have a people-centric, a patient-centric approach so that we ensure that we can improve the benefit package even based on the resources we have at hand. So we take note of the various challenges. As I had said earlier, the benefit package was guided by the prevalence or the disease burden in Kenya, what was causing deaths in Kenya, what was causing financial constraints, and the NHIF package, and what went well, what went less well on the NHIF package. So based on that, we were able to tweak the benefit package. Now, after that, these are 100 days after the rollout of SHA, we need to review the package, okay? There were some sentiments, there were some grievances. So how do we accommodate everyone based, again, looking at the pool of resources that we have. So those are the deliberations we'll be having right now and routinely in the near future. And that's why we are saying continuous quality improvement, whether it's benefit package, whether it's the human resource, whether it's the digital system, etc. Yeah, and because this project is for 2 to 3 years, or the program, for it to now become sustainable and stand on its own 2 feet, we are confident we'll get there.
My loved one or myself is admitted to ICU or HDU, and it's above and beyond what has been gazetted. Do I have to cover the cost on top?
I acknowledge, and I am from the profession. I understand very well critical care. We need to address it. And I'll be very honest, being a medical doctor, we are always honest, and I will tell you. The ECCIF, we did not have enough resources, as you could see from even the presentations that you had. We did not have, optimum resources to address the critical care component. Now, seeing the need and the grievances, we need to go back on board and review. How do we improve the funds for the critical care? And so that is where we are. We are again reviewing the benefit package for the critical care patients, and again reviewing the amount of money that is needed. So yet again, it is for us to encourage Kenyans to contribute. Because for a patient at critical care, they can even spend 300,000 in a day. So you can imagine if you have if you had 100 patients in an ICU and you have to pay critical care, the funds can be depleted very fast. So again, it is, as Kenyans have their grievances, let them consider that it's again about all of us contributing to support that person who's in critical care, and for us, in case anything happens to us. Yeah.
Speaking of, it's about all of us contributing.
Yes.
There's been talk of a public officer medical fund with comprehensive cover. Well, we all pay the same, 2.75% of our gross pay. Why are we not all entitled to the same benefits?
Thank you. That is an interesting question. Yes, so for the public officers, yes, they raised the concern. And as you can see, even for other private facilities, or other employers, when your employees raise their concerns and their grievances, they do get an enhanced cover.
And previously with NHIF, we're using biometrics. Now we are using a one-time password. Are we going to shift back to biometrics?
Absolutely. We need to shift back to biometrics. That is the only way we can curb corruption, yeah? Now, with the NHIF, the biometrics was just at facility level. So you would take your fingerprints. And what the healthcare providers, some of the corrupt healthcare providers were doing is they would take their own fingerprints. And their own fingerprints would be used for thousands of patients within the facility. So how do we curb that? By, merging or complementing that with the NRB. So that is the only way we can curb corruption, especially when it comes to the leakage of resources. And we're looking to have the biometrics. So they've been distributed in a few of the facilities, but we look to further distribution and ensuring that they are working seamlessly in the facilities. But at the time being, we're just using OTP.
Doctors, big issue has been the medical interns. Is a medical intern a student or a worker?
Yes. I always say a medical intern is in transition. They have graduated. They have their certificate, bachelor in medicine and in medicine and surgery. So we acknowledge that. Yet again, they need to go through the practical sessions. They need to have their skills and expertise, such as in cesarean section, okay, or other surgical procedures like amputation, etc. So that one, you only have it when you are in a healthcare facility. They are medical practitioners, but not licensed medical practitioners. There have been challenges in terms of many universities, both public and public, it's guided, it's standardized, but in the mushrooming private universities, we've had an overwhelmingly high number of interns coming out. Now, it has gradually increased because in 2017, the cost was 1.9, but at the time in 2023, it was around 5 billion if all of them could have been accommodated. So you can imagine, yeah, that you are budgeting 1 billion, and then the next time you have to look for 5 billion. So that was the challenge that was there. And even for the other cadres, you see some of them have increased 10 times their normal amount that had been anticipated because of the various universities. So as a ministry, now we have a challenge because where do you get the extra billions,
Is it extra because the 2017 CBA provides for 206,000?
There is an exponential increase in interns. Yeah, we cannot preposition, we cannot quantify, we cannot foresee what the quantity will be, and so we need to have that as a ministry to be able to have the budget. Now, we are not saying...
just for clarity purposes, when you say there's an exponential increase in terms of numbers?
Yes.
What are the numbers? The increase, yeah.
No, right now they are, I believe they're around 1,200, if I'm not wrong. So, you see, with that increase in number, how do you budget? And you see, it's not interns, it's not just the doctors. We have other cadres, okay? So we cannot anticipate for the next year, all right? That was the challenge.
Some of the arguments they've made, given what government has said about the interns being too many, is that the World Health Organization, for which you've worked, recommends a doctor-patient ratio of 1 to 1,000. Currently, Kenyan average is 1 to 5,000. And working conditions is a huge problem. We have 4,000 doctors who are out of work, and yet those interns are saying they're being overworked.
Absolutely.
So how can they be too many?
You know, it's the resources at hand. And that is why I come back to UHC. That is why we need to implement UHC. Because when you look at the FIF and you see that the resources are coming back and capacitating the facility, ultimately we'll be talking about human resource and how we can support them in that, so that we are not over-dependent in treasury, that when, you know, there's a movement, now everything is going, at the Ministry of Health, things are stagnating. We need to focus on our own being self-reliant. And that's why I'm saying the ultimate vision for Kenya, for Africa, globally, is having UHC and making it work.
There's been a shift from MES in the counties to the National Equipment Support Program. Why the shift?
First of all, it was costly for the country. Secondly, there was the mapping out was not done in terms of the staffing, in terms of the space, the connectivity, among others, in majorly resources. There was sitting down with stakeholders, with technocrats, reviewing. So this program is cost effective. It is accountable, it is transparent, it is sustainable. The mechanism of payment is actually different.
So how is it different from how MES has worked? MES has been a leasing program.
It was a leasing program. Now this one is fee for service. So based on the number of patients that you're seeing, that is how they pay the people who are giving us the equipment.
So 15% stays in the counties?
Yes. We are reviewing that because, again, there were challenges, so we are engaging the counties on a better way, but that was the idea before, yes.
So the bulk of this money would go to the people who are providing this equipment?
No, we are dividing so that a proportion goes to the people providing the equipment. The human resource utilizing, again, needs to go there, and the facility. Again, you know, there's power, etc., that is being used there. So all those things are being put in place. We are really breaking down to ensure that no one is going at a loss.
So how much is going towards the equipment, equipment providers?
The numbers. But I can assure you next time I'll have the numbers on my fingertips.
All right. What process, let me put it that way, was used in identifying those who will be providing this equipment?
Okay. So I came when the plane had already left the runway. So for me, I will review. Maybe I will give you feedback when I have the tangible evidence and I've reviewed the document. So
there are no mysterious, quote-unquote, mysterious suppliers?
I have not heard of any mysterious suppliers, yes.
The president on Jamhuri Day talked about parents accompanying their children to school to register for Taifa Care.
Edu-Afia was really looking at one individual child, and that child was in secondary school. But when you look at Taifa Care, it is covering a child right from 0 years to 18 years of age. And not only the child, but the whole family. So the mother, the father, and other siblings will be covered. So the money that you are paying for the Edu-Afia is actually the premium that we are using.
So are you prepared for that come January?
Yes, absolutely. We're working with the Ministry of Education to ensure that the children are also registered as dependents.
Kizuri chajiuza, kibaya chajitembeza.
Because people don't, because people don't understand it. They've not grasped the concept yet. First, yes, we will have the turbulence as we move up. Yes, we agree. But when we settle up in the sky, when we get to our destiny, which is Taifa Care, affordable, accessible, quality care to all Kenyans, I believe the story will change.